Hello, everyone, and welcome to our Canadian Association on Gerontology webinar series. Please take a look at your screen to see information about our upcoming conference, our annual conference that will be in October in Regina. And also just a reminder, if you haven't already, the call for abstracts has been extended, so you have until May 2nd to submit an abstract for presentation at the conference. So today in our webinar series, we're very pleased to welcome Dr. Judith Chipperfield. She is an internationally recognized scholar in the psychology of health promotion and disease prevention. Her interdisciplinary work explores the role of psychology in improving health, offsetting caregiver burden, reducing healthcare costs, and promoting longevity of older Canadians. Dr. Chipperfield has served in an advisory capacity, both provincially and nationally, to help shape the future directions of health research in Canada. Dr. Chipperfield's scholarly accomplishments include 325 reports, conference proceedings, chapters, and scholarly articles. She has generated $5.5 million in research funding from provincial and national agencies and has received many recognitions over her career, including numerous awards and prizes from her university and from CIHR. Finally, Dr. Chipperfield has been committed to training students. She has provided opportunities for them to collaborate in research networks across the globe, helping to launch the careers of many young scholars. And Dr. Chipperfield received the Canadian Association on Gerontology Award recently for contribution to gerontology. So she's going to present her work titled Adapting to the Challenges in Later Life, the Role of Mindsets. And just so everyone is aware, you will be muted during the webinar, but you're more than welcome to write any comments or questions throughout the session in the chat box at the bottom of your screen, and we'll have a discussion time at the end of Dr. Chipperfield's presentation. So thank you very much for joining us, Dr. Chipperfield, and you can introduce your session today that you'll be doing.
Okay, and welcome everyone, and thank you, Lori, for that introduction and for doing these webinars. This is really a great service for everyone. I'm honored to receive this award from CAG, and I would like to give a special thanks to Michelle Porter, who I see is here today. Thank you again, Michelle, for so graciously nominating me for this award. I really am indebted to you. What I'm going to do today is to play a video for you. This is a video of a talk that was recorded a couple of years ago, and it presents an overview of some of the research findings from my research program. I thought I would start by just giving you a little bit of backdrop to this video, and then I'll turn on the video and you can watch it, and then we could have some discussion after. There should be time to do that. So this talk that I gave was part of a celebration for the Center on Aging at the University of Manitoba. They were having their 35th anniversary. And many of you may know that the University of Manitoba had the first gerontology center in Canada. So it's been a remarkable resource for me and for many others. I've actually had a long tradition at the Center on Aging. I started in my involvement there as a graduate student, and then I did postdoctoral training there, and I've been a research affiliate there ever since. So I was really happy when I was invited to be part of their 35th anniversary to celebrate the Center on Aging. So I was glad to be presenting as part of that series. The audience for that presentation was very broad, and very many non-academic folks were there. So I tried to gear the presentation to that type of audience. So it's not heavy in statistics, there's not a lot of detail, but you'll get a sense of some of the research findings that I have presented over my career. So I will start by sharing my screen, and I'll bring up this video. Thank you, Michelle, and I'm just going to shift this a little bit just because I like to move around. Thanks for inviting me to be part of this 35th anniversary. My time with the center actually does go back pretty close to the beginning. I started with the Center on Aging in the early 1990s doing my postdoctoral training there. And since then I've been very involved with the center as a research affiliate, and the center is continuing to do great things. So thank you for inviting me to be part of this anniversary talk series. And I am going to today try to give you some background in the research that I'm doing. And let me start by saying I'm going to give you basically a brief overview. So I'll give you a little bit of backdrop, who I am and how I come at this. We'll talk a little bit about the overall objectives of my research. I'll tell you a little bit about the methods and a particular theoretical perspective that we use to try to study the psychology of aging. And then I'll mostly be telling you about some of our findings, some of the research findings that have come from our research, and some of the conclusions that we've drawn. And I'll end by talking a bit about how we're going to move forward, where we're going next. So that's kind of a snapshot of what I'm going to try to do in the next 35 or 40 minutes. I should have asked, should we still be trying to end certainly by 1? Is that the plan?
35, 40 minutes, I think is fine, and we can always end the question.
Okay, so that's where I'm going to go. Starting with me, how I got here, as Michelle mentioned, I am a psychologist. I'm a lifespan psychologist. So I actually started studying neonates before the children were born in the womb. I was studying that end of the developmental spectrum. Then I studied infants. Then I studied young children, and now I study young adults, but primarily older adults. So I really have come at this from a lifespan perspective. The research I'm going to tell you about today involves a huge team of people. So it's not just me that's been doing this research. I want to tell you about the team that's involved here. And this is, again, this is not going to, it's a slide that shows you who's been involved, but it doesn't include everybody. So what I want to point out is that we've had people from the U of M involved. I have collaborators from the U of M. I have collaborators from around the world, international collaborators, and many, many, many students and postdocs and research associates, some of whom I have listed here and some of whom are in the room today. So thank you for coming. So the work that I'm going to talk about is really a result of a lot of people's hard work and effort, not just mine. Let me start by saying that the basic overall research objective in everything I do is to try to look at the mindsets that people use when they face challenge. So when we think about aging, there's a lot of challenges, aren't there? Aging isn't for sissies, right? There's a lot of things we have to face as we get older. And how do we come at that? What are the mindsets that we use to help us adapt to these challenges that we face? And what are the consequences of those mindsets? So when we think certain ways, what consequences does that have? So that's what drives my research. And the premise is that mindsets matter. The mindset that you bring to a challenge does matter. It makes a difference to what is going to happen. So I'm going to tell you about some of our research findings, but I also want to mention that this is a conclusion that is actually gaining rapid media attention. So here's a headline from the Washington Post. It says, "Want to slow down your aging process? Mindset can be the key." So our research findings are really getting out to the media, and people are becoming really, really aware of the importance of mindset. Okay, let me tell you about, from my perspective, I take a very broad approach to defining mindset. What is a mindset? Well, it involves your beliefs, the strategies that you think you'll use, the expectations that you have as you approach life.
And I like to use the metaphor of a placebo. When you think about a placebo, we all know how placebos are used in drug treatments. Half the people in a drug trial get a particular drug, the other half get a sugar pill that should have no effect, right? But a lot of those people who take the placebo, the sugar pill, actually get better. And why do they get better? They expect to get better. So this really demonstrates the role of expectations, the power of expectations. And this is what I try to study, not the placebo effect per se, but I will get into what mindsets I study. Before I do that, I'll tell you a little bit about the methods that we use to try to conduct our research. And I want to acknowledge the late Betty Havens. Because Betty Havens, some of you in the room may know her. Her legacy to Manitoba was the Aging in Manitoba study. She has created this incredible resource for researchers based upon many, many, many years of hard work. So let me tell you just a little bit about that study. First of all, there was close to 9,000 participants in this study. The man you see on the left is actually my late father, who was one of the participants in the study. And what is done in the study is that we send interviewers out, and they go out into the homes of older adults, and they sit down with them and they interview them. They ask them questions. And so, in fact, the participants really enjoy this. And one of the stories that I always think was amusing is one summer, the interviewers were quite annoyed. And I remember having a conversation with them, and they were saying, you know, we phone these participants, and they're so excited that we're coming to visit that they start baking. And when we get to their house, we have to eat cookies, and we're putting on weight. So the participants in the study enjoyed these visits, they prepared for them, and this is great from our perspective, because we always like it if participants get something out of the study themselves. So this is what we do in the study. Now, let me show you the overall structure of the Aging in Manitoba study, because it's huge, and this next diagram really sort of captures it in one snapshot. So what happened in this study is, beginning in 1971, and then again in 76 and 83, we recruited, I actually wasn't involved at this point, but Betty and her staff recruited people for the study, 3 separate groups of people, and then followed these people over 35 years. So this is one of the longest running studies of aging, one of the longest in the world. What I was able to do, Betty was gracious enough to allow me in 1996 to come in and to carve off a part of this study and to actually conduct a satellite study where I was able to get much more in-depth information about the psychological profiles of these people. So in 1996, I started what we call the Successful Aging Study, and I have been following these people as well. I would like to point out 2 really remarkable things about this study, and that is, first of all, the study is population-based. What does that mean? That means that the people we brought into the study truly reflect the overall population in terms of gender, age, where they come from in the province. They really reflect the overall population extremely well. And the other important point is that in a longitudinal study, one of the things that can go wrong is you lose people along the way. But in this study, there was very minimal loss to follow-up. Very few people actually dropped out of the study. And that was solely due to Betty's relentless approach to making sure everybody in the study was contacted and involved in the study. So there's very little loss to follow up. And this actually involved, in some cases, because people from the study even came from remote rural communities, there was actually a time where, in order for the interviewers to get to the participants, one group of interviewers had to take a canoe into the remote community just to interview these people. And so the depths of effort that Betty put into retaining these people in the study was really remarkable. And why these two things are important is because they allow us to get results that we can generalize to the whole population. So this is, these aspects of a longitudinal study are really very important. All right, so that's what the study looks like. Now, I can only scratch the surface to tell you what kind of information we got from these people. But we measured them on many, many different measures of quality of life, psychological mindsets, which I'm going to talk to you about. We were actually also able to get some objective measures for some of these people. So we measured things like pulse. We measured their physical activity. I'll talk about that a little bit later with something called accelerometers. We measured their blood oxygen saturation. So we had access to objective measures. But what really makes this data set remarkable is we were able to link all this information to the Manitoba Health Claims data. So we were able to see if these people visit their physicians, if they're hospitalized. We're able to see if they live or die. And we're able to pull all this information together, which allows us to look at some really interesting questions. Okay. I measure a particular kind of mindset that I'm going to talk to you about. And it involves the idea of control. When we think about control, we see it all around us in society. Here's a picture of an album cover where the name of the album is Control. So this idea of control we see in music, we see it in literature. It's something we're all really familiar with. Look at the lyrics in this song. So the first song on this album is called Control. Here's the lyrics. This is a story about control, my control of what I say, control of what I do, and this time I'm going to do it my way, because it's all about control. I've got lots of it, I'm in control, and I love it. We love this feeling of being in control. I'm in control, don't make me lose it. We do not want to feel out of control. Everybody knows what it feels like to feel out of control. This is not a state we want to be in. So I'm studying mindsets that involve this notion of control. And if I were to ask you, do you think perceived control is adaptive? You would probably all say yes. You probably would all say yes. Why would it be that it's adaptive to feel in control? Now, when I think about control, what I'm really thinking about is your perception to be able to influence your world. If I want to do something, what's the likelihood that I'm going to be able to achieve it? Can I influence that outcome? So if we think about this, why would that be adaptive? Well, one really easy reason, and there's others as well, but this can-do idea, this idea that I can do it, is actually one that causes us to be persistent. It causes us to want to go after our goals, to strive for our goals, and to be persistent. And we see this message of persistence all around us. We see it in the bedtime stories we read to children. The little engine. I think I can. I think I can. I think I can. This is the message we want our children to learn and to embrace. So we see this around us. We believe it's adaptive. And in fact, when we look at the research on perceived control, and I'm just going to run you through some data here. When we look at this research, we actually find that it is, in general, the research says it is adaptive. And there has been an explosion of studies that have been examining perceived control. As researchers, we call this perceived control. And if you look at this next graph, you can see that this shows you that from 2000 to 2005, there's been an explosion of studies. Researchers are really studying this phenomena. They want to understand it. Now, in terms of what the research has concluded, I like to always show this little quote from Margie Lockman, because it really captures the breadth of the effects of perceived control. The personal sense of control is associated with being happy, healthy, wealthy, and wise. We know a lot about perceived control, and it really facilitates happiness. It also facilitates cognitive capacity. It has tremendous breadth to the consequences. Now, I'm going to show you a couple of examples from some of our studies. So when we study perceived control, what are we finding? Well, we find that perceived control is linked to a lot of really adaptive things. So, for example, we've studied perceived control with regard to loneliness. People who feel more in control say they're less lonely. We've studied perceived control with regard to day-to-day emotions, positive emotions and negative emotions. So people who say they feel in control are less likely to report feeling ashamed, feeling bored, feeling anger, fear, frustration, and they're more likely to say they feel proud and happy and grateful and hopeful. So perceived control has implications for your day-to-day quality of life, how you feel. We've also found that it promotes life satisfaction. People who say they feel in control also say they're more satisfied with their life. And we found that it relates to many, many other things. For example, independence, physical activity, health. I'm going to show you 2 slides to just give you a flavor for what we found with regards to health services. We're finding that perceived control relates to the use of health services. So I'll show you a slide to depict that, and then a slide also to show you that we're finding perceived control is linked to survival. So not just quality of life, quantity of life. Here's a graph from one of our studies, and what we did in this study is we were looking at individuals who had arthritis in this particular study, and we looked at the number of days that they had spent in the hospital a couple of years during the period following when they told us about control. So we measured their sense of control, and then we followed them for a couple of years, and we looked at how often they were in the hospital and how long they stayed in the hospital. And what we found is that for people who had reported feeling a low sense of control, they had on average about 9 days in hospital. Compare that to the folks who said they had high control. About 5.5 days fewer in the hospital. Now you can all imagine why that's so important. It's important because we don't want people to have to spend time in the hospital. It's also important because of cost, right? And we did a crude estimate to look at the difference in cost between people who had a low sense of control and a high sense of control, and the difference was quite remarkable. So are we spending more money on people who are out of control? These results would suggest yes. Let's look at the next graph. The next graph is going to show you the results that we found with regard to survival. And so if we look at survival, on this axis you see survival from 0 to 50%. I'm just going to close the door here. I think I am.
Slam it right to the back of the door.
Sorry?
You have to slam that lever right up and against the door.
It'll
that's
lock.
how it works. Oh, thank you. I felt out of control there for a minute.
I felt it too.
So if we look at survival, what do we find with these people? Well, in fact, at the end of the study, 36% of those who said they had high control were still alive compared to 15% of those without control. So is control affecting survival? What we do in these studies is we say, okay, we're finding this effect for perceived control, but how important is that? And as researchers, we could run some statistics, and we can determine the size of that effect. Is that a really important effect? That prediction of perceived control, being able to predict survival, is that important or not? Well, we can compare it to other predictors of survival that we know are important, like age. We know that as people live longer, they're going to survive less time, right? We know that women survive longer than men. So we can compare the effects of perceived control to the effects of gender and age. And what you see there is those comparisons, and really there is no difference in those numbers. Those are called beta values, which you don't need to understand, but it tells us that that effect of perceived control on survival is as strong as the effect of age or gender. So this psychological variable appears to be pretty darn important. Okay, I want to switch gears here. Is perceived control always adaptive? The literature, most of the literature says it is, but I'm going to show you some interesting results that cause us to say, wait, we have to dig deeper to understand this. So the answer is really no, it's not always adaptive. Paradoxically, perceived control can become maladaptive under some conditions. So we've done a couple of studies. I won't tell you about this one, but this is a study where we examined people who blindly persisted. So this idea of perceived control makes you want to persist. It's this I can do it attitude. But if you do that, and you don't also seek help when you need it, these blind persisters were actually at risk for some cardiorespiratory problems. So in fact, paradoxically, perceived control can become maladaptive. And I'm going to show you the results from a particular study, but I want to get you to think for a moment, to consider the mindset of an invincible teenager. We all know that teenagers are likely to do really high-risk things. So, but believing that you can control something, let's think of the teenager, believing you can control something and devaluing all the threats to your health could be pretty bad, right? We would all accept that. Here's an example. If you can believe it, adolescents are doing this now. Yeah. They go out to a parking lot, they get their friends, they go in their cars, and they get on top of the car and they surf. Pretty unbelievable. Now, we don't expect that older people are going to go car surfing, but could older people have an invincible mindset? Well, it turns out that we found that they can. So let me tell you about the results from another study, where what we've done is we've tried to identify people with this sort of an invincible mindset. So we first of all determine whether people say they have high control or low control. But then we also find out by asking them questions to what extent they value their health. So we can think of a 2x2 matrix here, and we can look at these 4 cells, and I'm just going to focus you on 2 of them. For simplicity today, to just give you some idea of our results, let's focus on this cell here. These are people who say they have high control, but they really devalue their health. Now you might say, come on, who devalues their health? Everybody cares about their health. And that's true, but some people more so than others. So we can identify people who basically say they don't value their health as much as many other things. And we think that this mindset could be maladaptive. So what we've done is we've compared this kind of person with this kind of mindset to people who we describe as motivated. These are people who have this strong sense of control, and they also have high value for their health. They really care about their health. So presumably, these people are motivated to do the right things, right? They want to be healthy, they do the right things. And in fact, this is what we're finding. So we are finding, I'm only going to tell you about 2 findings from our research, that this mindset, this invincible mindset, is associated with failing to seek help when you need it. So when you're sick, you're not going to your physician. And also shorter survival time. So let me show you these two graphs that come to this conclusion that this mindset may actually be pretty maladaptive. So here's the findings when we look at these 2 groups, and we're looking in this example at physician visits here and the number of years of follow-up. So we looked at these people over 5 years, and we found that those invincibles were much less likely to be going to their physicians. So presumably, going to your physician is a health behavior that can have good consequences. Maybe not always, but for the sake of argument, let's say that that's the case. And so these invincibles are not doing this. They're not engaging in these health behaviors. But even more dramatic are the results from something that we call a survival analysis, where we look at people's survival. In this case, it's over 13 years, and we're looking at the extent to which these two groups differ in their survival. And what you can see in that group of invincibles is that if you take any slice in time, 4 years, 7 years, 10 years, the invincibles are surviving less time than the motivated folks. And in fact, they have a 31% increased risk of death. So this kind of mindset is at least predicting much higher mortality rates. So we're concerned about these people, these invincibles. They're behaving in ways that probably are not very adaptive. Okay, so now I want to shift gears and I want to flip this on its head and ask a different question. So we know that perceived control is sometimes maladaptive. When is it most adaptive? And in order to talk about this, I'm going to tell you just a very little bit about a theory that we use. So this line of research is informed by a theory. This theory was invented by Bernard Weiner, who's a collaborator of ours at UCLA. And what he argues is that whenever we experience a challenge, we experience an event, it could be a failure, we're always looking for what the cause is. Why did that happen? We've studied this in young adults, and we've studied it in achievement settings. So we're able to look at young adults who experience failure. They fail a test. They're always asking why. Why did I fail? So when you come across in life challenges, particularly negative challenges that are unexpected, you're always trying to understand the why. And in Weiner's theory, he calls these attributions. So we're studying attributions. And the theory itself argues that every attribution or cause can be classified as controllable. Was that cause something that was controllable or uncontrollable? Was it internal? Was it something in me that caused this event? Or was it something outside of me? And I'm going to give you some examples to contextualize this. So let's just take one more step in this theory and think about these two dimensions. There's actually a third dimension in Weiner's theory, but I'm going to talk only about the controllability dimension and it's called locus of causality dimension. Whether the cause was due to something inside me or something external. So we'll look at some examples here just to flesh this out. The thinking is that we want people to have controllable and internal attributions because these are the ones that make you feel motivated. They make you feel responsible and motivated to make the right kind of changes to approach your challenges. So the notion is these attributions that we make have consequences. They have consequences for motivation. They have consequences for the behaviors that we engage in. So let's look at an example. First of all, I'll come to the example in a moment. We've looked at this idea in many contexts, as I mentioned, in achievement contexts with younger adults. With older adults, we've looked at it in terms of societal factors. What are the causes they think about when they're struggling financially? Are they causes that have to do with something that can be controlled and is internal to them? I didn't follow the stock market. I could have. Or is it external? So we've looked at it at these kinds of issues in societal context, in social context, in terms of loneliness. What's the reason I'm lonely? But I'm not going to talk about those today. I'm going to talk about two other domains where we've looked at this. One is within the context of health. What's the cause? You have a heart attack. You say, why did I have that heart attack? What's the cause? What's the attribution? We'll look at those data and also, in the physical context. So we're starting to look at this in relation to physical inactivity. What are the causes people give for why they're inactive? When you're inactive, you're sitting on the couch at home, you say to yourself, why am I doing this? You asking your question about the causes. Okay, so let's flesh this out. We've got these 4 cells that differ in terms of their controllability and locus of causality, internality, externality. And in the context of question, why am I ill? We ask people this question. When you've had a heart attack or you have a health challenge, why is it? What is the reason? What do you think is the reason? So a person might say, I smoked. That's why I have lung cancer, I smoked. They might say, well, I'm old. And in fact, when you go to your doctor and you tell them that you have a problem, sometimes your doctor will say, well, what do you expect? You're old. You know, that's the cause. That's why you're sick. So we have explanations, attributions like this. We might also talk about other things like our doctor doesn't care enough to give us the right advice, or we live in a climate that causes us to be sick. So all these kinds of causes someone could come up with for why they are ill. And we want people to think about causes that are internal to them, right? That because it's internal, there's something you can do about it, and that are controllable. So if we can get people to think that way, presumably this should motivate them to engage in the right health behaviors and presumably get better. So what do we find when we ask people about their attributions? What do you think the most common attribution is for being sick? Well, it is old age. And we call this the to be old is to be ill attribution. You believe that the reason you're ill is because you're old. And this is not a good way to think. Even if there's some truth to it, there might be a little bit of truth, still not the most adaptive functional way to think. So look at what this old age attribution predicts. People who say that their illness is due to old age, people who are on the high bar here, are 81%, the probability of hospitalization is 81% compared to people who don't use age as the attribution. We also find the same thing when we look at mortality. So when we look at the percentage of people who are deceased here, and we look at people who score on this attribution, high or low, we find 14% of those who don't see age as a cause are deceased after several years, compared to 36%. So people who are using old age as the attribution are more likely to be deceased. Okay, that's looking at attributions in the context of illness. Now I just want to show you a couple more slides looking at attributions in the context of inactivity. So when you're inactive, what causes to come to mind? What are the reasons you're inactive? I'm going to show you a couple of our findings here, but let me just digress for a moment and tell you that what we do when we measure activity in older people is we have them wear accelerometers, which is just like much like a wristwatch, and as they move around, it captures their physical activity. So this is an example of one of our participants in our study and their physical activity over the day, and they wear them at night too. So in this particular case, right in here, the person is in bed at night, but you actually see there's a fair amount of activity at night too. So we can do some interesting things with these measures of physical activity. This is how we measure physical activity. And so what we're trying to do in these studies is look at people's attributions. So again, we've got the 2x2 matrix, and when we ask people to tell us the answer to this question, why am I so inactive? They tell us different things. They give us different attributions, different causes. So they tell us, for example, I'm not trying hard enough. It's one reason people aren't active. I could try harder. They tell us, I just don't have the ability, which is a little bit like an age attribution, isn't it? And it's in that same quadrant. It's uncontrollable and it's internal. And they might tell us, it's the fact that I don't have somebody to help me. It's somebody else's fault, it's not me, it's external to me, or it might be that the task itself is too difficult. So these are just examples of what people tell us. And luckily, the most common is the kind of attribution we do want people to make. It's to say, I'm not putting in enough effort. If I tried harder, I could actually get up off the couch. I could actually be more physically active. So this is a good thing. But we're also finding that some people are telling us that it's because they lack the ability. And this is the detrimental, this is the really bad way that we don't want people to think. And we are finding that people who think that way in our studies are being less active. So thinking that way presumably limits your motivation to want to be more active. And so these people are less active. And they also have a greater odds of death. So again, this way of thinking is related to survival. Pretty incredible if the way we thought actually had implications for how long we're going to live. Okay, so that's what we've been doing in our research. Now I'm just going to spend a couple of minutes telling you about where we're going. So we're moving forward, and what we want to do is develop, we've started this process, develop something called an attributional retraining program. Trying to get people to think differently. Sounds easy, right? No. Not so easy. Okay, let me lay it out just to give you a snapshot of what we plan to do. We do in research what's called a pretest. So before we actually start intervening to try to change things, we take some measures. So we start with a pretest and we measure people's attributions. We ask them, why are you inactive? They tell us, well, I'm not trying hard enough. They tell us I'm just too old. They tell us all these reasons for why they're inactive. And then we also measure their physical activity using these accelerometers. So at baseline, we have all these measures. Then we're going to come in and we're going to develop and implement what we call an attributional retraining intervention. And I'll come right back to that in just a moment. But before I do that, what we then do after that is maybe a year or so later, we go back and we again measure the same things that we measured at pretest. So we again measure their attributions after they've had this intervention, and then we measure their physical activity. Okay, let me tell you about the intervention. We're doing two things. We're developing a video, and we're developing something called a CAM task. I'll tell you about the CAM task in just a moment. So in both of these, the real goal is to get people to shift from the maladaptive attributions they're using to start thinking in a different way. Start focusing on different reasons for their challenge. So we're developing a video where we have an older adult talking about his reasons for why he's inactive. And then his neighbor is giving him advice. His neighbor is saying, well, the way I think is this way. So we're trying to get people to see, okay, here's how I think, here's how my neighbor thinks, and then we come in and we say, your neighbor's actually thinking in a better way. So we want you to think more like your neighbor. So that's what we do in the video. And then what we also do is we show people how they're thinking. So we've measured all their attributions at pretest, and let's say we have 8 attributions. For each person, they get a score, telling us which quadrant their attributions fall into. So we might find a person who gets a score in the top right quadrant there. Remember, that's the one we don't want. So these people are people who are more likely to be saying the reason they are inactive is they're unable, they're just too old, they have bad genes, their father passed on their genes for diabetes, all these kinds of reasons. And they might be true. There might be some truth. But we don't want them to focus on those reasons. We want them to switch their way of thinking and to start using adaptive attributions like, well, I'm not trying hard enough, or if I use different strategies, if I just said to myself, okay, today I'm just going to do a little, but I'm going to do something. If they used a different strategy, this might help them to become more physically active. So this is where we're going with our research. One more slide, just to try to recap. So, why are mindsets important? I've tried to give you some data that to convince me that my mindset is important. But what are the implications of this? Well, I've talked about healthcare costs. It might be that if we could get people to think differently, this could have implications for the budget, the amount of money we spend on healthcare. It could also have implications for what we could help physicians think about when they're trying to figure out what they tell their patients. So if a patient comes in and the physician's sitting with the patient, if the patient could identify this person and say, oh yeah, this is an Invincible. We've got to be careful about this person because they're going to ignore their risks to health. If the physicians could understand this, this might help them to target individuals who are at high risk and intervene in appropriate ways. But really, maybe the most important message is that if we could get people to think differently, this would just simply help them to age well. So that's the message that I want to end on. And just as a final note, I always have to acknowledge the incredible support that we get to do this research. So we've been funded really, really well by the Canadian Institutes of Health Research in a number of different ways. We've received funding from a variety of other sources, including SSHRC and some local sources. And we have also used the Center on Aging resources that have helped us to move forward with some of our most recent research and going back further as well. So I'll end there.
Well, I hope you were able to grasp the main issues that I was raising in the talk and get a sense of what we've done over the last years and where we're going. So Lori, if you want to sort of coordinate the questions or comments, that would be terrific.
Sure, yes. So if anyone does have anything they'd like to bring up, we do have your microphones muted, but please just use the chat room at the bottom of your screen. So there is a question here from Christine Judith. So her question is, how is perceived control measured? If it is a scale, what are some example questions?
Well, we actually measure it using 10 items. And what we're trying to do is measure perceived control in different domains. So usually the questions that we ask are a series of questions that people score on a 10-point scale. So we ask them to tell us how much they perceive they can influence things in different domains. Can you influence your health? Can you influence your physical activity? Can you influence your leisure? Can you influence your pain? So we ask them about perceived control across 9 different domains and then a general item. So that's typically how we measure it, but many other people in the studying this measure it in different ways. So that's just kind of an example of what we've done.
Great, thank you. I've been, as you were talking, I was thinking about, you know, we've dealt now with over 2 years of a pandemic where a lot of control was taken away from people in a lot of ways. Has your research team done any work around COVID and mindsets and perceived control?
I wish I could say yes, but the closest I can come is to say that we were conducting a study just as COVID hit. So what we were doing, we've tried to develop this intervention that I had described in the video, and we were trying to implement it in a pilot study that took place in the Riverview Health Center. So the Riverview Health Center has a day hospital where people come for the day and they spend the day and they have some tests done and they socialize together. And we were able to conduct a study, pilot study, to have some people in the Riverview Health Center view our attributional retraining video. And we conducted the small pilot study looking at how active they were before that and after that, comparing them, of course, to a control group. And unfortunately, we had to end our study early because, in fact, COVID did hit. We don't have data per se that deals with the sort of the impact of COVID, but we have been able to follow some of those people over time in order to obtain measures some months later after COVID had started. And we did ask people about their perceived control again later. So we haven't analyzed that data yet, but I guess we could all kind of speculate about what we might think. And did COVID, did the factors involved in COVID have a negative impact on people's perceptions of control? Well, my best guess would certainly be yes, it probably did. But the interesting thing is, what I would like to look at, we don't have data on sufficient participants, but what I would really like to look at is the people who were able to maintain their perception of control despite the complications and challenges of COVID. So really interesting question. I wish I had data to look at that. I don't have good data, but I do have some that I will be able to look at.
Great. So you recorded this for an event with the Manitoba Center on Aging a few years ago. Is there some things that you've been working on since? You talked about some next steps. Have those changed a bit, or are there new things that you're working on?
Well, as I mentioned, we developed the intervention, and we spent a lot of time doing that. So we did focus groups where we got feedback from participants, and we were able to modify the video to try to improve it. And now we have actually implemented it, and we have some data to look at whether, in fact, we were able to change people's ways of thinking, change their attributions as a result of viewing the video. So we're now looking at that data, and we have some promising data that fairly convincingly shows that people who watch the video did shift in terms of their mindset. So when we measured their attributions before they watched the video and after they watched the video, we were able to show that they did change some of their attributions. Now, interestingly, the one attribution that did show significant change over time was the attribution to old age. And that is, I think, probably the most important attribution that we need to look at and focus on. But interestingly, the attributional retraining didn't seem to change people's thinking about other causes. It was mostly about the attribution to old age. So once they watched the video, they were less likely after the video to say the cause of my inactivity is because I'm old. And that's great. So we're now just digging into that data and trying to analyze it. And then, of course, the next step would be to conduct a more fully developed study with a larger sample size, because for this pilot study, as is the case for most pilot studies, we only had 45 people. So, you know, we're limited in terms of what we can say about that data. So the next step would be a more fully developed study, which I would like to say that we can do, but I might have to wait for the next generation to take that one on. So we'll see.
There was a comment, Lois had mentioned that she had worked in this area as a student in the 70s, and just interested that there's still a lot of interest and research in this topic. She mentioned it was locus of control,
Right.
But quite similar. So yeah, there's definitely still a lot of important work to do. Let's see, a few more comments coming in here. Leona, so you were talking about interventions, and so it might have been before you mentioned that, but Leona said, what strategies can you use to move people from that maladaptive to more adaptive? So you talked about that video. Are there other strategies or interventions that are promising?
Well, we've developed interventions as well for younger adults, as I mentioned in the video. So we've studied younger adults who face failure. So they face the failure of a test and they try to understand why. And so what we've done with them is develop these videos to try to get them to think differently. But this kind of technique could be extended to other methods. So for example, instead of a video, it could be done through a package of information that's presented without the video format. And that might actually be very viable for some populations. But I actually think that the video is probably the one of the more impactful ways to present this information to people, because you can develop the intervention in different contexts. So we've developed it in the context of students who have failed, and we've developed it in the context of adults who are inactive, but you could develop it in the context of many different areas. So I think there's a lot of promise for the use of videos in the attributional retraining, but it's not the only way you could go, for sure.
Mm-hmm. Yeah, Lois comments that some work that she's doing right now is looking at the role of technology to assist a specific group of older adults, vulnerable immigrant seniors, to remain control over their lives, and using different types of technology to communicate with people, for example. I'm not sure if that's in the particular context of COVID, quite possibly if it's being done recently. Oh yes, actually Lois just mentioned that was in the context of COVID, and there has been, yeah, with being able to continue to have those interactions with people and have some control over social connections. I think a lot of technology has been used in the last few years. Sandy brought up an interesting point. I was thinking of this too in your presentation. She writes, I think older adults may experience self-imposed ageism from society. Is there anything you wanted to comment on about that? So like, this sort, like you're really combating a lot of issues around ageist beliefs around utilizing services and health and things like that.
Well, the old age stereotype, yeah, can be internalized. So it's me who thinks that way, or it can be imposed on me by the world around me. And of course, the old age stereotype, I don't want to come down on physicians for this, because when physicians send the message to patients that their problems are because they're old, it's true, right? I mean, as we get old, our bodies wear out and health problems evolve. And so it's true that is part of the explanation for why we are ill. But if we could then maybe if physicians could explain to patients, well, in fact, this is an age-related disease, but that's not what you should focus on. You should be thinking about things that you can do yourself to make the situation better. Whatever it is, there's always ways to make the situation better. So the messages that come from others around us, they cause us to have this self-imposed notion of old age as a stereotype, and anything we can do, of course, to soften that or reduce the impact of that is something that we all should do. Not only physicians, but all of us should do that.
Great, thank you. So I think we are almost out of time. So there is some other comments there. I believe that the comments, the chat room is published along with the video, so you can take a look at some other things that are listed there. But I want to thank all of you for attending our CAG webinar today, and of course for Dr. Chipperfield for presenting her interesting research findings. So thank you very much for that. And please join us for our final webinar of the season, which will be on Thursday, May the 19th. So please plan to join us at the same time. And thank you very much for connecting in, and have a great day, everyone. And the video will be posted as well, of course.
Thank you.
Thank you.